Okay. Today our guest is coming now because our guest is a very interesting person, not a very important, because this is not very interesting for us, but he is very interesting because he has been for a long, long time the chief of the children department of the University of Pavia. Then he has a very large experience of these problems, not only technical problems. You know that my suggestion is to take in consideration that our problems as doctors are not only technical problems, okay? We can solve a lot of technical problems because the normal evolution of techniques give us the possibility to improve our methodologies and technologies. But you have to take in consideration that we have a lot of ethical problems and to cope or to afford when you have a new case. When you take care of someone, of course, you have to take care also. You have to take care also of all his personality. Okay, this is very important. Then. The person and then the well-being. Probably it's clearer for you to think to the well-being. First, yesterday we discussed with our guest on coma and how to do to afford as best as possible the coma. Today, I think that it's interesting for you because yesterday we didn't have enough time to see this video. We have a first video, and yes, the link is the first one. Please, for the people not in this. Not here with me, you can go on your laptop and to check and to find this link, okay? These are 3 links. Why you use TED? Because I don't know if you know this platform, but it's interesting for you because it's one of your tool in the next years. Could be also a scientific tool, taking consideration that Oliver Sacks, one of the most important neurologists of this last century, decided to give his will on TED.com. Okay, the last conference of Oliver Sacks was on TED.com. Okay, this is important just to give you the idea of this platform. If you have a new idea, you go on this platform and you make a conference. 2 years ago, one conference was in Rome. I don't know if someone of you had the possibility to participate. Anyway, it was very interesting. I participate with Professor Boccanelli, of course. And then it's one of other common passions. Yeah. And then we see this video together. Then I wait for your questions, okay? Because I think there is a word, Gomer. She talks, of course, she talks English during the video. You have the subtitles. If you think it could be useful for you, you can change the subtitles because on TED you can change also the subtitles. But here in the classroom you have the subtitles in English. And please listen with a lot of attention the words because Gomer is very very, very interesting word. It's a slang word, but very interesting because you have from this word exactly the idea of your importance when you speak in a word, okay? You have to pay a lot of attention because you can use inappropriate words. First, second, just an information for all the students, because one of yours asked me about one of the conference not completely in English. Okay, we are solving the problem with Marco Trombetti, and probably you will have a translation or probably a registration with something like a record with a translation. We don't know, but we asked him to give you the translation because sometimes it's very easy if you are not my English mother tongue to have this problem, to change language and sometimes. Okay, first we see this video, please pay attention. I wait for your questions. Thanks.
I'm actually going to share something with you I haven't talked about probably in more than 10 years. So bear with me as I take you through this journey. When I was 22 years old, I came home from work, put a leash on my dog, and went for my usual run. I had no idea that at that moment my life was going to change forever. While I was preparing my dog for the run, a man was finishing drinking at a bar, picked up his car keys, got into a car, and headed south or wherever he was. I was running across the street, and the only thing that I actually remember is feeling like a grenade went off in my head. And I remember putting my hands on the ground and feeling my life's blood emptying out of my neck and my mouth. What had happened is he ran a red light and hit me, my dog. She ended up underneath the car. I flew out in front of the car, and then he ran over my legs. My left leg got caught up in the wheel well, spun it around. The bumper of the car hit my throat, slicing it open. I ended up with blunt chest trauma. Your aorta comes up behind your heart. It's your major artery, and it was severed, so my blood was gurgling out of my mouth and foamed, and horrible things were happening to me. I had no idea what was going on, but strangers intervened, kept my heart moving, beating. I say moving because it was quivering, and they were trying to put a beat back into it. Somebody was smart and put a big pin in my neck to open up my airway so that I could get some air in there, and my lung collapsed, so somebody cut me open and put a pin in there as well to open up to stop that catastrophic event from happening. Somehow I ended up at the hospital. I was wrapped in ice and then eventually put into a drug-induced coma. 18 months later, I woke up. I was blind, I couldn't speak, and I couldn't walk. I was 64 pounds. The hospital really has no idea what to do with people like that, and in fact, they started to call me a gomer. That's another story we won't even get into. I had so many surgeries to put my neck back together, to repair my heart a few times. Some things worked, some things didn't. I had lots of titanium put in me, cadaver bones to try to get my feet moving the right way, and I ended up with a plastic nose, porcelain teeth, and all kinds of other things. But eventually I started to look human again. But, well, it's hard sometimes to talk about these things, so bear with me. I had more than 50 surgeries, but who's counting? So eventually the hospital decided it was time for me to go. They needed to open up space for somebody else that they thought could come back from whatever they were going through. Everybody lost faith in me being able to recover. So they basically put a map up on the wall, threw a dart, and it landed at a senior home here in Colorado. And I know all of you are scratching your head, a senior citizens home, what in the world are you going to do there? But if you think about all of the skills and talent that are in this room right now, that's what a senior home has. So there were all these skills and talents that these seniors had. The one advantage that they had over most of you is wisdom, because they had a long life. And I needed that wisdom at that moment in my life. But imagine what it was like for them when I showed up at their doorstep. At that point, I had gained 4 pounds, so I was 68 pounds. I was bald. I was wearing hospital scrubs, and somebody donated tennis shoes for me, and I had a white cane in one hand and a suitcase full of medical records in another hand. And so the senior citizens realized that they needed to have an emergency meeting. So they pulled back and they were looking at each other and they were going, okay, what skills do we have in this room? This kid needs a lot of work. So they eventually started matching their talents and skills to all of my needs. But one of the first things they needed to do was assess what I needed right away, which I needed to figure out how to eat like a normal human being, since I'd been eating through a tube in my chest and then through my veins, and so I had to go through trying to eat again, and they went through that process. And then they had to figure out, well, she needs furniture. She is sleeping in the corner of this apartment, so they went to their storage lockers and all gathered their extra furniture, gave me pots and pans, blankets, everything. And then the next thing that I needed was a makeover. So out went the green scrubs and in came the polyester and floral prints. We're not going to talk about the hairstyles that they tried to force on me once my hair grew back. But I did say no to the blue hair. So eventually what went on is they decided that, well, I need to learn to speak. So you can't be an independent person if you're not able to speak and you can't see. So they figured not being able to see is one thing, but they need to get me to talk. So while Sally, the office manager, was teaching me to speak in the day, it's hard because when you're a kid, you take things for granted. You learn things unconsciously. But for me, I was an adult and it was embarrassing, and I had to learn how to coordinate my new throat with my tongue and my new teeth and my lips and capture the air and get the word out. So I acted like a 2-year-old and refused to work. But the men had a better idea. They were going to make it fun for me. So they were teaching me cuss word scrapple at night. And then secretly, how to swear like a sailor. So I'm going to just leave it to your imagination as to what my first words were when Sally finally got my confidence built. So I moved on from there, and a former teacher who happened to have Alzheimer's took on the task of teaching me to write. The redundancy was actually good for me, so we'll just keep moving on. One of the pivotal times for me was actually learning to cross the street again as a blind person. So close your eyes. Now imagine you have to cross a street. You don't know how far that street is, and you don't know if you're going straight, and you hear cars whizzing back and forth, and you had a horrible accident that landed you in this situation. So there were 2 obstacles I had to get through. One was post-traumatic stress disorder. Every time I approached the corner or the curb, I would panic. And the second one was actually trying to figure out how to cross that street. So one of the seniors just came up to me and she pushed me up to the corner and she said, "When you think it's time to go, just stick the cane out there. If it's hit, don't cross the street." Made perfect sense. But by the third cane that went whizzing across the road, they realized that they needed to put their resources together, and they raised funds so that I could go to the Braille Institute and actually gain the skills to be a blind person, and also to go get a guide dog, who transformed my life. And I was able to return to college because of the senior citizens who invested in me, and also the guide dog and the skills that I had gained. 10 years later, I gained my sight back, not magically, and I opted in for 3 surgeries, and one of them was experimental. It was actually a robotic surgery that removed a hematoma from behind my eye. The biggest change for me was that the world moved forward, that there were innovations in all kinds of new things, cell phones, laptops, all these things that I'd never seen before. And as a blind person, your visual memory fades and is replaced with how you feel about things, and how things sound and how things smell. So one day I was in my room and I saw this thing sitting in my room, and I thought it was a monster. So I was walking around it, and I go, I'm just going to touch it. And I touched it and I went, oh my God, it's a laundry basket. So everything is different when you're a sighted person, because you take that for granted. But when you're blind, you have the tactile memory for things. The biggest change for me was looking down at my hands and seeing that I'd lost 10 years of my life. I thought that time had stood still for some reason and moved on for family and friends, but when I looked down, I realized that time marched on for me too, and that I needed to get caught up, so I got going on it. We didn't have words like crowdsourcing and radical collaboration when I had my accident, but the concept held true. People working with people to rebuild me, people working with people to re-educate me. I wouldn't be standing here today if it wasn't for extreme radical collaboration. Thank you so much.
I hope you have appreciated this video because it's interesting. Okay, it's
a few months ago.
No, stop. Okay, because this is the story of a re-education after a trauma accident. You have seen this. You have heard the story, and then I watched the video, and then she explained very well how this car accident has changed her life, how long has been the re-education, and then you have seen all the damages she had at the beginning, and now then she has in the group of Cinderella, the pumping has been the carriage. Okay, now we have this slang among us about Cinderella. When I talk about Cinderella, this is our dream. Okay, to change our patients and to give them the possibility to change their life, to improve their lives. As before, they have before to be ill. Okay, now I think do you have any question before Professor Bazzoli? Gomer, you know what is Gomer? Have you checked on, because I told you at the beginning, please check the word Gomer. Have you checked? Did you check the word Gomer? Because this is slang. Please check. And remember that the patients are able to listen everything. Have you found it? Okay. Do you understand now? Then now you have checked, and now do you understand the importance? Because when you give a classification to someone saying oh, this is a poor thing, or something like that. Gomer is like poor thing, okay? It's, you don't have any possibility, okay? This is important because the patients, also patient, as yesterday we have seen in the video of Professor Gabriella Buzzi, is listening to you, okay? Then remember, because you are making a big job, but if you are destroying at the same time by words, could be a problem, okay? Then, Professor Bozzoli, I'm very proud, I told you I'm very proud to introduce you these colleagues, because these colleagues are low-profile colleagues. They are part of my personal network, mine, Professor Boccanelli too, and then if they have something in common is the high profile and the high profile for the career, for the publication, and so on, but a low profile when they talk with us, with normal people with us, okay? Then,
I lost myself because I lived just 3 years ago in a small town, Pavia, and the Pavia is, I think, a quartier of Rome. And I just imposed my navigator and arrived 20 kilometers again. I doubled my trajectory, and I am very sorry. It's the first time for me. Thank you very much. Your Chuck is very enthusiastic for me. C'ha ragione. I took my lecture in Egypt, in Argentina, in another country, but it's the first time that I arrived late. Okay, I'd like to I'd like to thank my colleague and friend Laura Pacifici because of your passion. I am here, and I received some proposal of a conference to give you, but I chose the transition from fetal to neonatal life because is a topic of great interest for last few hours, but which has a strong effect on the future on the child. I am pediatrician, that I speak about children. The protagonist of this fascinating, fairly detail occurring every day is the subject presented in this picture, called the fetus during pregnancy, and neonate or newborn is the same after birth. Each pregnancy and delivery is different, and the problem may arise. Labor and delivery are the processes by which the fetus and the placenta leave the uterus. But what is this labor? Labor is a series of continuous progressive contractions of the uterus that let the fetus move through the birth canal. However, me lo posso vedere, lo faccio con la freccetta. Penso che si veda così. However, the exact trigger for the onset of the labor is unknown. Uterine muscle spasm that occurs at interval of less than 10 minutes may indicate that the labor has started. Active labor after goes on 4 or 8 minutes or more. What is delivery? Childbirth is the ending of a pregnancy where one or more babies leaves the uterus by passing through the vagina or by cesarean section. Delivery can occur through the vagina or by a cesarean surgical delivery. A cesarean delivery is a surgical procedure in which a fetus is delivered through an incision in the mother abdomen and uterus. The word cesarean derives from the Latin verb caedo, to cut. A little question for you. Cesarean section is performed by a vertical on the left or horizontal incisor. Have you ever wondered why most women prefer horizontal incision? No answer?
Did you understand the question? No.
I repeat my question. Why most women prefer horizontal incision than vertical incision for the cesarean? Okay?
Due to what can remain something like cicatrice, non so come si dice.
Yes, it's a very good answer. Because when after giving birth, they go to get a tan during the summer, they will want to hide the incision under the bikini. This is a question, is not an academic question or a popular question, but it's a practical question.
It's a joke, of course, it's a joke. But, you know, sometimes our doctors are joking, but it's not so easy to understand that we joke because we don't change our face, our mood. It seems to be very, very serious. Okay, this was a joke. But it's interesting why this joke is interesting. Because sometimes patients, you think that some patient is asking you something because it's very important, because could be ethical, or could be religious, or could be practical. No, it's a problem of a bikini. Honestly, it's not a problem of bikini, because the patients also, if they ask for this kind of incision, they don't know that this incision is better for the muscles. Okay? Because you don't open, you don't create a space between the two long muscles. Then there is something practical to do this when the obstetricians decided to do this kind of incision is not to be nice with the patients, but because they know that it's better for them, okay? Then there is a joke, but there is also a mood to understand when you have a relationship with the patient. Is it correct?
It's correct. It's not quite a joke, because sometimes the patients have a conflicting discussion with the obstetrician gynecologist, because for obstetrician gynecologist it's easier the vertical incision in the emergency. But the pregnant women, the mother, prefer the other incision. And sometimes there is this discussion, and sometimes is the mothers prefer this incision, and the gynecologist obstetrician is obliged to perform the horizontal incision. This is the practical life. Okay, a little bit of history. Pliny the Elder wrote that the Roman Emperor Julius Caesar was named Caesar after a progenitor who was born by Cesarean delivery. In the past, the Cesarean section procedure was used to save a baby from the womb of the mother who had died while giving birth. This procedure is applied for the mother not died. And this is important because it's the only fashion to save a child in emergency. Health care provider use the term high-risk pregnancy to describe the situation which a mother, her fetus, or both are at higher risk for problems during pregnancy or delivery than in a typical pregnancy. A high-risk pregnancy may be one that involves a chronic health problem, such as diabetes, or high blood pressure, or infection, or complication from a previous pregnancy. A pregnancy can be high risk because of a women's age, chronic age, health condition, lifestyle, and other factors.
Just a question, just a comment. It's important. This I wanted to underline for you. I wanted to underline for you this concept. When we have chosen this topic for this conf lecture, was because it's interesting that inside you have seen the framework is very technical. How to make birth, how to give birth to, or to make a child delivery. Okay, this is very technical. You have two types, but you have more than, because you have these are Cesarean, but you have also other kind of things you can make. Okay, but inside there are a lot of ethical problems. For example, when you have probably you have participated to a conference on fertility. Okay, the conference on fertility, they have discussed the methods, the methodologies to have a good result. Okay, but close to the good result, you have the ethical problems. Okay, the methodology could help you to make to have a baby, to make a child delivery. Okay, but the price, inside the price to join this result, this target, you have inside a lot of ethical problems. And then on these ethical problems, we discuss okay? Because we discuss a lot, we discuss not only by among technicians, but we discuss, for example, in the Senate, and then it's important because from these discussions we have laws, okay? And then you have to cope with the laws. Then it's important to be part of stakeholders, knowing that to be a stakeholder, you can also give your opinion, and then to be a good influencer, okay? Good, sorry.
Good, no, nothing. The transition from a fetus to newborn is the most complex physiological adaptation that occurs in a human experience. Changes in body and organ function occur to allow the fetus to adapt to extrauterine life and to begin to function independently. Some neonates present risk because of underlying congenital abnormalities, for example, problem of heart, birth injury, or disease. The transition has to occur quickly for survival of the newborn. All organ systems are involved at the same level, but the major immediate adaptation is the establishment of air breathing simultaneously with the changes in pressure and the flow within the cardiovascular system. Other essential adaptations are striking changes in endocrine function, substrate metabolism, and thermogenesis. The primary function of a circulatory system of both the fetus and newborn is to deliver oxygen to organs and stock up the oxygen and to eliminate the waste product of carbon dioxide, CO2. During pregnancy in the fetus, the gas exchange organ is the placenta until the birth. The fetus needs a constant supply of oxygen during the perinatal period, immediately before and after birth. This oxygen is supplied by the mother through the placenta and the umbilical cord when the baby is born and can breathe on time. In the picture, you can see the fetus, the placenta at the bottom of the uterus, and the umbilical cord linking the placenta to the fetus. The fetus needs a constant supply of oxygen during the perinatal period immediately before and after birth. This oxygen is supplied by the mother through the placenta and the umbilical cord until the baby is born and can breathe on its own. With the birth, the function of gas exchange is transferred from the placenta to the lungs. So the transition from the fetal to neonatal circulation include elimination of the placental circulation.
Mauro, a question for you. When you discuss technically all this topic, of course, you don't discuss with the patient, because if a lady comes to you, she knows all these things, she decided not to have a baby, for sure, because it's too complicated. Then, how to explain, for example, to an old mother, because now we discuss with, I am the first one, I have a baby, a child. I have a child, and I had my child not really young. And then we have Francesca too. Then how to explain that there is all these passages are complicated, are not easy, and then at the same time not to stop the idea to have, for example, a baby, because we are doctors It's easy for us. We have studied during our course of medicine that it's not easy to have a baby because it's a long process. But how to explain to a mother, a possible mother? Because, of course, this is an ethical implication.
Luckily, I am pediatrician, so I arrived later. But my colleague, gynecologist obstetrician, has to explain carefully these processes of the fetus to the neonate, and he has to explain exactly the risk of this transition, but he has to explain that in the rooming in, there are a neonatologist, this is a pediatrician who care the baby, anesthesiologist, nurses, and so on. There are very doctor with the same problem around the birth of this. So the majority of a mother is very happy to have a lot of person around in order to ask a question, to have any detail about the birth. But it's not easy.
Okay, thanks. And then it's important for us because, of course, we go back to the discussion we had yesterday. You have seen, you have watched in the video today. When you have a complex problem as yesterday or 2 days ago, okay, you have a team. Okay, it's impossible. You can decide to be surgeons if you like, but anyway, also surgeon needs to have a network with work. Okay, this is very important. Professor Bozzola is giving you all these informations because you didn't make, of course, you are young, and then you didn't make the course of neonatology, or then you need more information. For this reason, he is giving you some information more on the process. But it's important to understand that you are in front of a complex problem. In generally in medicine, now we don't have easy problems. Okay, maybe if you have a flu, sometimes it's a complex problem. Okay, then take in consideration that you have to be part of a network, and then because you have to ask a lot of questions. If we talk, because we are in a course of ethical, okay, ethics course, moral philosophy, for example, take in consideration when you think to the surrogacy, okay. For example, you have a contract with someone to make a baby, and then all this process is not making by yourself, okay? This is, I don't want to judge, to give you my personal idea, but I think I would like to give you like a click to think on it, okay? This process is not so easy, it's long, with a lot of implications, okay? Imagine when you make a surrogacy, okay? Thanks. Sorry.
No, nothing. We continue. The complications. A severe disease occurring during delivery is the hypoxia, that refers to a lower than normal concentration of oxygen in the blood. The fetus can survive only for a short term without sufficient oxygen. In case of prolonged oxygen insufficiency, severe asphyxia occurs, associated with the coma, intractable seizures, and intracranial hemorrhage, and death may occur. What is this word seizure? A seizure is a sudden electrical disturbance in the brain. The patient makes uncontrolled movement of the arm and the legs and does not respond to vocal or tactile stimuli. Seizure types vary by where they begin in the brain and how far they extend. Most seizures last from 30 seconds and 2 minutes. A seizure that lasts longer than 5 minutes is a medical emergency. In this picture, you can see a seizure that could be tonic or clonic. Tonic is only the spasm, clonic in the movement. The neonatologist must be able to act without delay if one unexpected problem arises affecting the baby's life and health after delivery. So survival usually is associated with a poor long outcome. For fear of complication that may occur during childbirth and to avoid the pain during delivery, pain of the mother, some pregnant women insistently ask to undergo a cesarean section. 2 important points must be considered. First, a vaginal delivery is safer for the mother and not riskier for the baby. Cesarean is often safer than a vaginal delivery in case of a danger posed to the mother or baby due to a medical condition and reduce the death and the illness in both the mother and the baby.
Okay. This is, for example, an ethical dilemma. An ethical dilemma is which kind of child delivery you have to decide for the baby and for the mother, okay? Because we have started our course discussing on different religions and position from different religions, but of course it depends, because for someone it's more important to save the baby, for someone it's more important to save the mother. Then this is an ethical dilemma, because a procedure could be safer for the mother but not for the baby. And then if we go back to one of the first slides Professor Bozzola showed you, if you remember about Julius Caesar, of course, after the cesarean, he was alive, his mother was alive, and then for one of the reasons for which he was considered like God, okay, was because it was the first time the fact it was something completely exceptional, okay? Did you understand? It was exceptional to have both alive, okay? Then it's very important because this is an ethical dilemma. And then this ethical dilemma you have to discuss also with the father, for example, because the mother and the father, we have discussed about the different positions last week, about the possibility to take care of someone till when to take care of someone. Okay, when you have a child, you have usually you have a mother and a father, and then the positions sometimes couldn't be exactly the same. Okay, this is another ethical dilemma. Okay, then you have a solution by the law. But the position, the ethical dilemma for the doctor is to explain and to cope with these different positions. Please.
We will discuss about bioethical implication of this procedure, delivery, vaginal or cesarean delivery. But it's important to understand that for a mother, it's quite easier to have a cesarean section. Avoid the pain and avoid the probability to see the complication of the delivery. But for the obstetrician, for the neonatologist, for the surgical, it's better to have a vaginal delivery because it is natural, it's not artificial. We discuss it later about this. However, it must take into consideration the cesarean delivery is a surgical procedure that can involve risk like a surgery, for example, complication of anesthesia. Therefore, it must be performed only in selected cases. In the case of an elective cesarean section, maternal mortality compared to spontaneous birth is more than double due to hemorrhage, sepsis, thromboembolic pathogenesis, and anesthetic complication. Moreover, contrary to popular belief, the increase in the number of cesarean sections has not decreased the incidence of cerebral palsy and neonatal seizure. We discuss later the cerebral palsy is the big problem of the brain of the newborn, but this continues in the adult life. It can result in increased risk of being admitted to intensive care, hypoglycemia, breathing problem, less breast research. Okay, bioethical implication. No medical reasons that influence the decision to perform cesarean section are the subject of medical and bioethical discussions. The question to be answered is, can a pregnant woman demand a cesarean section based on her right to make decision? Do such a request and the permission given by the mother justify the physician to perform the procedure without a clear medical indication, knowing that the cesarean section is associated with higher maternal morbidity and mortality rate than the vaginal delivery? It is important to think about this problem because what is very easy in medical area is not today the best solution. Among the reasons stated by pregnant women or their family when demanding cesarean section, the question is focused on the labor pain or the risk of a dystocia childbirth.
What do you think about? Is it right of the lady to ask which kind of delivery or child delivery, or is not right? Please. Now you know a little bit better the topic, then you can give your opinion. What do you think on it?
Well, okay.
Do you want to do a gynecologist?
No.
No, unfortunately. Okay.
Well, hello, my name is Alberto. Well, first of all, I think that in any case, we have to inform really good the patient about the risk of both procedures. So this is really important. But then I think that the question you just made, me as a male, so a person who will never give birth, I'm not the right person to give you an answer because I cannot find myself in the position of living this in first person, so to have to give birth and go through this pain. So I think it's better to ask this question to some women.
Okay, I told you a little story, a little personal story. Okay, I love procedures. I love, not I like, I love procedures because my first specialization was at the beginning to be an anesthesiologist. And then, of course, I know everything. But when my child was born, she was purple. The color was purple, violet. And then the colleague came to me saying, it's better to put her in resuscitation space. I thought, okay, I made a mistake. Why I didn't ask for a cesarean? Okay, this is a story because a short personal story to explain that your point of view is completely different when you are the protagonist and when you are the actor of the story, or you are not the actor, you are the writer of the story, or you are the okay. It's very important to know which kind of position you have in a story.
Yeah, this is absolutely my point of view. I cannot be an actor, so I cannot answer well the second part. But I think it's important to be informed.
Yeah, but when you are a doctor, you need to make also an advice. Please. Okay, thanks.
I think that in your future profession, you can be faced to some matter. You can explain what you want, but for some matters, the decision is just done. You can explain it's not a real pain. You have a team of specialists and so on. For some other, you can speak a 2 hour, 20 hour, today, and so on. But when decision is just done, you cannot. You have to attend to go to perform what she wants. This is in my experience, because I have a daughter. My daughter is 45, and I remember for the second sons, the problem was a very compact with my daughter and the obstetrician, but at the end, is my daughter decide what she wants. We continue. When a pregnant woman makes a decision that may be detrimental for the health and the well-being of the fetus, her physician may be faced with an ethical dilemma. Is the physician's primary duty to respect the woman's autonomy, to promote behaviors that may be in the best interest of the fetus? It's very complicated. For Canadian law, if a mother is competent and refuses medical advice, her decision must be respected, even if the physician believes that her fetus will suffer as a result. And for other countries, I can report only the International Federation of Gynecology and Obstetrics, that in connection with the World Health Organization has published a position statement. This is a rule. This is the law for us. Ethics and professionals guideline. Decision-making about the vaginal or cesarean delivery. Recommending vaginal delivery. The obstetrician should explain that when there is no evidence-based support in cesarean delivery, vaginal delivery is safer than cesarean delivery for both the mother and baby. This is for vaginal delivery. For the other, recommending cesarean delivery should be recommended as the only medically reasonable alternative if and only if there is a certainty of an evidence base for the clinical judgment that cesarean delivery is clinically superior to vaginal delivery, the other position. Offering both vaginal and cesarean delivery is quite an Italian mediation. This vaginal delivery and cesarean delivery should both be offered as reasonable alternatives if there is no clinical certitude about the benefits and rises of each. The positions are very different. It's not an artificial discussion. This is a lecture for me. But when you will be in a delivery room, the problem is faced to you. It is not easy to have an answer for some matter. Responding to patient requests. Sometimes a patient may request a mode of delivery that the obstetrician gynecologist does not recommend. The obstetrician gynecologist should explain the evidence base for the recommendation that was made. The patient should be asked to reconsider, especially if her reason supports the obstetrician gynecologist recommendation. If, after this effort, to inform the patient request have been completed and she is therefore able to make an informed and voluntary request, it is ethically permissible to satisfy a request. Just a moment. For our category, for physician, when you ask to the mother to sign, that is her voluntary, is her right to decide her decision. For law, you are not completely quiet, because some judge can reply, but this mother have been informed carefully about the risk of cesarean section. You have to answer yes, but you have not a paper documentation. You have the signature, but the signature in some moment of the life, you can imagine it's only a signature, not a real suffered decision. I don't know if it's clear my position question. It's not easy to begin, doctor. My experience with my face, I am not a young doctor, but I had sometimes this situation between obstetrician and the mother. But the obstetrician asked me to have more support for his decision. Preventive Ethics is very strange as name, because the ethics is difficult to be preventive. But the obstetrician gynecologist should take advantage of a prenatal visit to initiate decision-making with the pregnant women about the clinical management of her pregnancy, including intrapartum management. We have to start before. This is known as a preventive ethic approach to decision-making with pregnant women, pregnant patients. Last consideration, the reality that a low-risk pregnancy can suddenly and without warning become a high-risk pregnancy should be explained. The potential of this change to make cesarean delivery must be considered for either mother or fetal indication, for example, fetal dystocia. The mother is convinced to have a vaginal delivery, but at this moment, during this delivery, something changes. For example, unexpected problem. What is this fetal dystocia? Fetal is abnormal fetal size or position resulting in difficulty to delivery. The fetus blocked during this descent. Diagnosis is by examination, ultrasonography, or increased duration of the labor, more than 8 hours. Treatment is with the physician maneuvers to reposition the fetus, operative vaginal delivery, or cesarean delivery. In this picture, you can see on the left the normal position of the fetus, normal presentation. The fetal head is engaged downwards. Fetal dystocia may occur when the fetus is too large for the pelvic opening, fetal-pelvic disproportion, or abnormal positioned. Example, breech presentation. What is breech presentation? Is indicated by, in my picture, is the bottom of the neonate is engaging downwards instead of earth, and the delivery can be completed because the fetus can die in this tragedy. Is the damage suffered by the newborn mother the result of unexpected complication, or is the consequence of a medical error, and therefore can it be classified as a medical malpractice case? It's very difficult to separate this position, explain an unexpected complication or my mistake. If the staff attending the birth failed to respond to an appropriate standard of care and the child suffers harm, the family may request a fair compensation for the persistent damage. It's not a problem of money. I am obstetrician, I'm not an pediatrician, but if I am obstetrician, I have to respond to the mother, to the father, to the relatives, to my colleagues, to the keeper in the delivery room, but I am to respond to the law. Because it's not easy to make this profession mainly as obstetrician. Gynecology is not easier, but not so difficult. And I have to respond to my conscience, I have to respond to the love. And in a real, not in lecture, but in real situation, you have to reflect about this. Another important current question is, should parents be allowed to interrupt pregnancy in the case of a mental retardation and or disabilities? This matter is subject I'm sorry. The matter is subject to discussion among obstetricians, coroners, jurists, and religious. This is the big problem, because if you think this mother will have, after delivery, she will have a child, not a normal child. Child, for example, with Down syndrome, the Mongolism. This will be an adult with disabilities, permanent disability. My question is, I have to continue the pregnancy of this mother, or I have to interrupt and give another possibility to the mother to give a normal child? This discussion on the termination of pregnancy is not my specific competition because I am a pediatrician. Therefore, it will not be discussed by myself in this section. Vuoi dire qualcosa?
Thanks a lot. For the first time, we are discussing about preventive ethics, okay? Usually, it's not very common, for example, when we discuss about ethical problems, dilemmas, models, ethical models, and so on, we don't use preventive ethics. But in English, because this course is in English, is very common to use this term to explain that you have to prevent, you have to discuss before all the dilemmas you can have. Then, why it's important? Because to discuss dilemmas, you need to have a table, a clear framework when you have put all your doubts or your dilemmas, etc., etc. Why? The second reason is that if you use this kind of attitude about preventive ethics, you can also not to afford, for example, a malpractice. Okay, now you are starting to do how not to be attacked in justice. Okay, one of the problems yesterday, I was reading an article of this point. A lot of people decided at the moment not to be surgeons because they know that they can have a lot of malpractice. They can be attacked by their patients for malpractice. And then malpractice is insurance. If you have a high insurance to pay, you have to put on the balance your work and your insurance and malpractice, because it's part of the cost of the insurance. Then to use preventive ethics could be a good system also to make a different balance. Okay?
We continue. At birth, the dependency of the fetus from the mother through the placenta via umbilical cord is finished. The adaptation to external environment suddenly starts. From intrauterine to extrauterine life, there are some functional and morphological findings which allow the fetus to adapt to postnatal life. The assistant to the neonate. Careful nursing care are needed during the period of transition to ensure that appropriate interventions are initiated. In the delivery room, just after the birth of the neonate, the nurse puts the neonate on a rigid table, sucks up of the mucus from oral cavity and noise to open airway to avoid the choking. Cuts the umbilical cord. After the first clinical evaluation, we perform a cleaning bath, a conjunctiva prophylaxis, and at least a prophylaxis of hemorrhagic disease by intramuscular injection of vitamin K. What is the hemorrhagic disease? Is a coagulation disturbance due to vitamin K deficiency. As a consequence, there is an impaired production of coagulation factors by the liver that leads to death. APGAR score is a rapid scoring system performed at 1, 5, 10 minutes based on the physiological response at birth and a good method for assessing the need to resuscitate a newborn infant. This in the picture is represented what is the APGAR score. It's based on 5 parameters with the score from 0 to the max value for APGAR score is 10. You have to remember only 3 points. The APGAR score in less than 4 when the neonate present a severe cardiopulmonary depression. This is to resuscitation. APGAR score between 4 and 6 when neonate requires close attention, and APGAR score between 7 and 10 is normal cardiovascular adaptation. We must evaluate these 5 parameters and give a score. And this score is important not immediately, but for the future, because the future brain lesions can come back to these problems in a neonatal period, in the delivery. It's carefully recorded by APGAR score.
This is one of the problems when for which you can be attacked for malpractice. For example, you didn't treat in right time, for example, a low APGAR score, and then of course you can have problems because from this score you can have you can understand something for the future. It depends. Just a very short comment for you. Take in consideration that the evaluation of APGAR score changes a little bit according to the places, okay? Of course, for example, the baby is very pale or is very pink, okay. Of course, the rate is not the same if we are in Rome or we are in London or we are in India, okay? Then it's important. But you have to cope also with this kind of score.
Sometimes when a child has a disability, you have to find in the dossier, in the record of this child, which was the APGAR, because sometimes it's the only justification of the cause of disability. It's very, very important. Virginia APGAR was an American obstetrical anesthesiologist. She was a leader in the field of anesthesiology and introduced obstetrical consideration to establish field of neonatology. To the public, however, she is the best known as the inventor of this APGAR score, a way to quickly assess the health of newborn immediately after birth. Follow-up of the neonate to check. The nurse checks. Measurement of body temperature, heart rate, respiratory rate, color of a body every hour till to its stabilization. During the first 20 hours of life, to check the production of urine and meconium. Meconium is the first feces. Nutrition should be promptly started. Neonate should be fed every 2 or 3 hours. always supporting maternal breastfeeding. After this first observation phase, the neonate goes to the rooming in. Peculiar attention should be paid to the care of the umbilicus cord until it falls. Adaptation to external life. For survival, 3 points. Respiratory adaptation, circulatory adaptation from the fetal to neonatal flows, body temperature maintenance. First is the removal of the fetal lung fluid from mouth by a small suction cannula. Second is the stimuli for the first breathing. The first stimuli is the tactile. You remember in some film, old film, you have this picture on the left, the obstetrician that taps the baby's butt to make him breathe. Actually, in the present, we are more soft in the induction of this breathing. Second stimuli is thermic. Because our fetus lived in the uterus at 38 degree temperature, and now is at 25 degree into delivery room. So the drop is very important, 13 degree. This is very important for induction, the breath test. When you pass from a room very hot to a outside or in a room very cold, your first impression is to check breathing. And for the neonate is the same. Another is the chemical, because when the fetus lives at the moment before delivery, it increases carbon dioxide, CO2, before breathing. The third is the lung ventilation using surfactant. Surfactant is a natural substance which prevents the pulmonary alveoli from collapsing, injected in trachea but in intensive care. The other metabolic adaptation, glucose metabolism, is very important because you have to differentiate the preterm infant from term infant. Preterm infant is the child born before the 37 weeks. And they have a low amount of glucose, so a little fall of glucose for them is very important. It's called hypoglycemia. And hypoglycemia less than 25 milligrams per deciliter and less than 35 milligrams per deciliter among term infants, it induced the seizures. Sì, dimmi quando. Tu mi interrompi. Allora finisco un attimo questo. Ok. Body temperature is very important. As you can see on the left, we have the degree. 38 degrees, the temperature in the uterus. For us, is 30 for adult. For the other baby, is at 36. But in the first hour of life, the temperature drops by 2 degrees, 2-3 degrees in the first hour and rises within 5-6 hours. Maintaining body temperature is important for the newborn. Hypothermia is not compatible with life. It's very interesting, the adaptation of a body temperature for the fetus newborn. Brown fat, which make up about 5% of the body mass, is localized on the back, along the upper of the spine and toward the shoulder. It is of great importance to avoid hypothermia, mainly in premature infant. It is the same fat that bear use to stay warm when they hibernated. We have only our human fetus and the bear using the same brown fat. Calcium metabolism, the most important, because hypocalcemia is done when the level of calcium is less than 7 milligram per deciliter. In this picture, you have the calcemia, the level of calcium on the left. The normal is 10, and the risk is below 8. And in the first 20-hour life, there is a drop. Then later, there are a recovery of the level of calcium. The problem is when the neonate present hypocalcemia. Some neonates are asymptomatic, but they may present with hypotonia. Hypotonia is loss of muscle tone, apnea, failure to breathe, interruption of the breath, tetany, contraction of the muscle, and seizure that you have seen. It is an emergency situation to be treated immediately with infusion intravenous of calcium. The other adaptation is the cardiovascular. Because a fetal shunt closure is the separation of the circulation of small circle. You can see in this, faccio questo, poi mi fermo. You have four phases of the adaptation of cardiovascular adaptation. The first phase is dilatation. The second is expulsion. The third is disengagement. The fourth is breathing. You have to remark the heart rate of the neonate. You remember what is your heart rate? Sorry.
17?
I am old.
Maybe around 84 minutes.
84 minutes, okay.
Yeah,
But when you meet your girlfriend,
maybe a little
is
bit
more.
Yeah, it increases.
And for neonate is the same, because for neonate the normal heart rate is between 120, 140. This is more for the neonate than for adult. But during the expulsion, we have a little drop, but not very important. But during the disengagement, you can see on your left, when the fetus go outside, the heart rate drops to 80, 70, 80. This is bradycardia. And bradycardia is one of the situation of death of the neonate. And he has to monitor it carefully, because sometimes we lost, it's very, very rare, but we can lose the neonate during this moment. After the first breathing of the neonate, the heart rate rises to 170, 180, and so on. we can stop one more.
Okay, I think that we can stop now because this lesson is very dense for you, is full of new concepts, and sometimes these concepts are very technical, I can understand. But anyway, I think that could be useful for you, if you understand from now, I don't know, in 4 or 5 years, that you can make an ethical, a preventive ethics. Then you can, how to make a preventive ethics. First, if you ask yourself, what I have to explain to the patient, what I have. Second, a journalist, one of my friends, very well-known journalist, used to say, I make a question when I know the answer. Okay, it's very important in our job. It's very important before making a question, before explaining something to the patient, to know the possible answers the patient could give you, okay? Why? Because the first thing is not to be completely displaced, not to be completely without any idea, any answer. You need to have an answer. And then from your answer, the question of the patient, you can start to make a discussion, okay? Because you don't have it's clear for this presentation that you don't have, as doctor, to accept everything. You have, okay, a big part is accorded to the law regulations in different countries, but it's also a personal problem, okay? This is very important. Then you need to make questions to yourself, then to give you some answer, and then to talk with patients. Please don't make the mistake to talk with the patients before, because there is a big mess, a big confusion for the patient. If you are not clear, the patient are completely, usually they try to find another doctor, okay? Because they don't consider you a support of them. It's a technical support, an ethical support, a empathetic support, nothing, okay? Then it's very important to think before. Then, if you have any question, Professor Bozzola is here, but he will go back here for the next conf lecture. Then, of course, it's technical, I know, but this is more or less the risk we had when we decided to make conf lectures, because in all the topics there is a technical backgrounds to take in consideration. Do you have any question? Yeah, thanks.
I wanted to ask, but to Professor Pacifici too. Which are the main reasons which drives mother to choose between a cesarean delivery or a natural delivery, if we know that the cesarean one is better, either for the mom, both for the mom and for the son, probably because it's a surgical, I don't know, it's something surgical. And
okay, thanks for the question.
My
personal point of view, because this is personal, but it's the fruit of lectures and so on. Okay, my personal point of view is, as in Bocconi they used to say, it depends. Okay, there is not the perfect child delivery. The child delivery it depends a lot from the from where you are at the moment. Okay, for example, if you live in Netherlands, it's perfect to have a vagina child delivery, because you have the ambulance waiting for you at the door. Okay, you have your child delivery, you bed in your house, because usually in the Netherlands are small houses. Okay, and the ambulance is waiting for you. If there is a problem, the ambulance pick you up with the child, and then in 3 minutes you are in the hospital, and of course it's perfect. Okay, this is the perfect child delivery for mother, not of course in the age. Okay, because the age is changed in the last years. When I was very young, 35 was terrible, was a very old age for the first child. Now it's not the old age, of course. And then it depends. You have to, for example, I don't know if someone of you would like to work in Asia or in Africa. Of course, in Africa or in Asia, in some places, it's better to choose a vagina child delivery. In Italy, it's probably less traumatic to have a cesarean, but it depends on where you are. It depends a lot on the lady. Then I think that you have, as always in medicine, to find the perfect balance between the technique, the lady, and the doctor. Because, of course, my professor used to say, my first professor used to say, we use the technique we know better, okay? Of course, we don't use a laudano to make anesthesiology, but something a little bit new, but of course we use, all the doctors use the technique they know well. Then it depends also from this point. Okay, I hope to have answered. Okay, other questions? No? Okay, thanks.
Okay, goodbye. I'm Isabella Faraoni. So my question is an ethical problem. So no, we
For
generally
Professor Bozzola?
yes.
Okay.
We generally accept that is a child is living after breathing. Okay, the breath and you are live, but there is some time among when you before to start the breath. Is in this time is life the child or is not life, and why the child, the newborn, start the breath? What is the stimulus? Why?
I don't understand. Sorry, the breathing or the breathing. Sorry. There are the three tactile stimuli, but nobody knows why the newborn start to breathe. Because it's the chemical stimuli, tactile stimuli, thermic stimuli, we don't know. But at the moment with the newborn goes outside, the first action of the obstetrician is to tap, because the tactile stimuli is the more important for him. But we prefer the soft maneuvers, but the first maneuver, very efficacious, is the to tap the blood.
Is not absolutely necessary.
I remember the delivery of my wife when my colleague, I was in the room, gave my daughter the fit, and the taps, I cry, slowly, please. But is the normal act for the obstetrician, because it's the most efficacious stimuli for the breathing.
I can say something very funny. Okay. I have a long practice as a doctor in emergency, many kind of fields. Okay, because I worked a lot abroad, and then you can't have a colleague, you can't phone, etc. You have a lot of practice, but when my child was born, I didn't want to touch her because, and then at a certain point, the pediatrician arrived saying, please, you have to take your baby in your arms, and then it's easy. No, but it's mine. And then it's mine if someone belongs to you, your kind of behavior is completely different. Then a practice, a good practice, a normal practice, is different. But of course, when you are on the other side, we see that sometimes it's a little bit aggressive, probably, but it's normal. It's useful. But of course, our perception, and we have discussed a lot with our students on perception, because the perception of the doctor is different from the perception of the patient, of the family of the patient, etc., etc. Then it's important to remember which is your role, and then if you are the pediatrician, if you are the gynecologist, if you are a parent, or etc., etc. Then I think that it's important. I don't know if I answered to your question, but it was important for me to underline this concept.
No, this is a specific question. Why the baby start to breathe? It seems that there is another stimulus important. Some authors declare, say, I don't know if possible.
Because the
brain is not function.
There are a lot of possibilities to stimulate the baby. I'm not a pediatrician, but of course, when the upcar is low, the first person who used to stimulate the baby is the anesthesiologist. And then, of course, you try by the trachea, you can touch, you can do a lot of. The most important thing is to to start the process, okay? The problem is not which is the pathway, also if it's a very short time, but the problem is the target. The problem is sometimes the baby is a little bit lazy. It's important to push him to breathe in a short time.
Thanks.
No.
In fact, I don't agree with the English colleagues about the delivery at home, because my colleague said 3 minutes from the home to the hospital for the emergency. In London, as in Rome, I don't know if there are only 3 minutes or 30 minutes. And when the newborn don't breathe until exactly 9 minutes, the nervous cells died. And the nervous cells are not replaced with the other cells, but the structure not qualified, not specified. This is the very important cause of disabilities in the adult life. I prefer give my wife to the hospital, in roaming in a delivery room, and I have my friend, colleague, gynecologist, obstetric gynecologist, my friend anesthetist, my friend surgeon, my friend nurse, and my friend neonatologist, because I am pediatrician, but I'm not able to care a neonate at birth, because I have not experience. And my colleague neonatologist has not experience, like me, to care a newborn, a child after the first hours of life. We are very specialist. This is my opinion.
Okay, from this point, very, very quickly, in my experience, I'm very proud for one thing. I made a child delivery alone because I was between two checkpoints, okay, during a war, and then I didn't have any possibility not to make the child delivery. I was completely alone with an interpreter, a driver. And then I didn't have enough time to arrive to the hospital. Honestly, I was sure to arrive in time, and then sorry, I made the child delivery. Just for some, I told you this for one specific reason. Sometimes it's not possible to have a staff with you, a team, a network. Sometimes you have to make alone. Then my personal advice, my personal advice is remember that it's better to work in network, but sometimes it's not possible. Then try to make the best experience you can, because it could be very useful. Sorry. Thanks, Professor Bozzola. Sorry, guys. Do you have a question? I'm very sorry, but I am not able to stop the phone. Okay, this is the problem. Yes, of course, you make your intervention.
Yes. No, I wanted to tell that 2 years ago I went to South Africa, and I was in a little village, and over there, ladies couldn't go to the hospital because the hospital was overcrowded of people that were in surgery or whatever. So almost of the ladies that had to delivery, they deliver not even in the houses, but like in big rooms, we can say, but without drugs, without anything. So I don't know the percentage of ladies that die here in Italy, but I think it's very, very, very low. Over there, it's very difficult to be alive after the delivery. So for here, it's strange that a lady or a woman, even if you are old, can die. But I remember that over there, ladies that have children are usually 20, 25, even younger. Yes, I was just when you described your, your...
Yeah, this is more or less also my experience. Sometimes really you have some condition which you have to, sorry, I don't understand why, it's completely crazy, my phone. Anyway, I think that it's important to make the best experience you can. Please go to make stage, to make all these things, because these are really important to make a good background for your profession. Thanks, Professor Bozzola. Thanks to everybody. Thanks to Francesca Temperini to be my support and her staff, because you are really good, really fantastic to help me in every kind of things. Thanks a lot.
Thank you. Thank you very much.